Today we'll talk about membranoproliferative glomerulonephritis, which is basically different from other types of proliferative glomerulonephritis due to many reasons. Okay? So let me describe what is mean. Normally, this is what happens in proliferative glomerulonephritis is, if you look at this picture, the black circle is representing the basal membrane in this diagram here, and the red dots is basically showing capillary endothelial proliferation, and the blue one is showing the mesangial proliferation. So most of the proliferative glomerulonephritis, they have mesangial proliferation, they have capillary endothelial proliferation, and they may have a Bowman cells proliferation as well, but usually the basal membrane remains intact. That's a pure proliferative GN. Okay, so membrane, the glomerular basal membrane remains intact. It doesn't split, but there's inflammation and proliferation of the mesangium, which is blue in this picture, and capillary endothelium, which is shown by the red dots within the capillary. And there may be proliferation of the Bowman cells making crescents in the green area. Okay. In the second, compare this proliferative pattern with the pure membranous pattern without any inflammation. So in the pure membranous pattern, mesangium remains normal, which is these tiny blue dots here. The capillary endothelium, the red circles inside the basal membrane remains normal. Bowman's capsule remains okay, but the membrane, see, compare this single layer of the membrane, okay, with this membrane, where the membrane has split into multiple layers and has widened up. This is pure membranous. If we combine both these patterns together, there's a proliferation pattern. The mesangium is proliferating, capillary endothelium is proliferating, and the membrane is also opening up. As I said, normally in the pure proliferative glomerulonephritis, membrane doesn't open up. Glomerular basal membrane remains normal. In the pure membranous pattern, it's only the membrane which splits up, which opens up, which widens, which becomes leaky, and the collagen dispersion is there. But there's no proliferation. The mesangium remains normal, the endothelium remains normal, the Bowman cells remain normal. In the membranoproliferative, compare this one at the bottom. Okay. Now, if you look at this picture, there's a proliferative component. The mesangium is proliferative, which is blue here. The capillary endothelium is proliferating. The red dots within the capillary. And look at the membrane. Membrane is also splitting. So both is a combination of buff two pattern. Proliferation of the mesangium and endothelium, and also the splitting of the basal membrane, which are happening simultaneously. When both the process of the proliferation plus the membranous split happens together, this is called as membranoproliferative. As the name indicates, there's a membranous pathology that the membrane will become weak and leaky and it will disperse. The collagen in the basal membrane will disperse, plus the mesangium and the capillary endothelium will also proliferate. When both the processes are happening simultaneously, which happens only in the membranoproliferative, this is the only proliferative GN in which both these phenomena are happening together. The splitting of the basal membrane and the proliferation of the endothelium and the mesangium. Okay? In that case, now because both the processes are happening together, the mesangial cells, they actually start invading into the basal membrane. Look at the blue, which is coming within the basal membrane between the two black layers. Okay, this causes splitting of the basal membrane into two or multiple layers, and it looks like a railway line or tram track appearance. Histologically, this is called as tram track appearance, which is a diagnostic hallmark of membranoproliferative. If I will go back again to the pure proliferative without membranous component, the membrane is not opening up, a membrane is not splitting, and mesangium is not entering into the membrane. In the pure membranous one, membrane is open, membrane is wide, membrane collagen has dispersed, but because the mesangium is not proliferating, so mesangial cells, they don't penetrate into the basal membrane. In the membranoproliferative, because both these phenomena of the proliferation and membrane splitting, they are happening together. So mesangium actually start entering into the basal membrane and split the basal membrane into two layers or multiple layers. This multi-layering of the basal membrane is called as tram-track appearance or splitting of the basal membrane or right. So this is the basic difference between the membranoproliferative. The other clinical difference which is important is because in the pure proliferative pattern, there's only mesangium which is expanding and the capillary endothelium is expanding. So they compromise the capillary lumen. In the membranous, there's only one factor which compromises the capillary lumen, which is the thickening of the basal membrane and widening of the basal membrane, which causes narrowing of the capillary lumen. Whereas the membranoproliferative, all these phenomena are happening together. So capillary lumen is severely compromised. It is compressed by the expanding mesangium. It is compressed by the proliferating endothelium, and it's also compressed by the thickening and dispersion of the basal membrane. So patient with the membranoproliferative GN, they have a severe compromise of the capillary lumen, and that causes severe reduction in the renal blood flow, fall in GFR, and uh, worsening of the renal functions. So membranoproliferative pattern basically is the most severe form of proliferative GN. Okay, but it's a combination of proliferative GN plus membranous GN. So both things are together. Now, the third important clinical fact which we need to understand between the membranoproliferative one, because there's a proliferation, that proliferation is because of the inflammation that will cause rupture of many of the capillaries. So that rupture of the capillaries causes nephritic pattern, glomerular hematuria, and acute renal failure. Whereas membranous split, remember the first rule for the proteinuria was damage to one of the three layers. So in this case, because the basal membrane is becoming leaky, so patient has a proteinuria as well. So membranoproliferative GN basically has a variable combination of nephrotic syndrome because the membrane is involved, collagen in the basal membrane are dispersing, membrane becomes leaky, and the patient start losing proteins. So patient can have a variable degree of proteinuria, which can even range to the nephrotic syndrome. Secondly, because there's inflammation as well at the same time, so that will cause nephritic pattern, glomerular hematuria, and acute renal failure. Let's go back. In pure proliferative GN, because the membrane is intact, okay, there's just an inflammation, so there's a capillary rupture that causes pure nephritic pattern. Proteinuria is not in the nephrotic range. In pure membranous pattern, because one of the three layers is damaged, so patient has pure proteinuria or nephrotic syndrome, but usually doesn't have any nephritic component. In membranoproliferative, because the membrane and the proliferation are happening together, inflammation is there. So there's rupture of the capillary plus membrane leakage. So that there's a combination of nephrotic syndrome as well as nephritic syndrome. Depending upon which component is dominant, if the basal membrane is predominantly involved, in some cases, patient may have a dominant nephrotic syndrome with less dominant nephritic pattern. If the inflammation is more than the membrane involvement, then the patient may have a predominant nephritic pattern and less dominant nephrotic pattern. But classically, patient often has nephrotic and nephritic syndrome together. Okay, in case of membranoproliferative. Now, what causes membranoproliferative is the same mechanism as any other diseases can cause. There are two main types of the membranoproliferative gene. One is immune complex mediated. There is immune complex formation due to any reason. For example, there's an infection, there's a infectious antigens, cancer antigens, drug antigens, or autoimmune antigens. They have antibodies. The antibodies, they combine with antigen, they make immune complexes, and immune complexes they deposit in the glomerulus to activate the complement system, and that complement system will bring the inflammation there. So one type of the membranoproliferative GN is basically immune complex mediated, okay, which is immune complex deposition in the subendothelial location and in the mesangial location. Okay. If you compare it with the post-infectious glomerulonephritis, post-infectious was pure proliferative. There was no membranous involvement. So, okay, number one. Number two, in the post-infectious glomerulonephritis, there was subepithelial deposition of the immune complexes. In this case, membranoproliferative one, there's a subendothelial and mesangial deposition uh, of the immune complexes, right? In some cases, there may be subepithelial deposition as well. There are basically three types of immune complex mediated MPGN. Type 1 is subendothelial and mesangial deposition. Type 2 is predominantly basal membrane. And type 3 is predominantly subepithelial deposition in addition to the subendothelial as well. If you don't remember these types, that's still okay. But just remember, membranoproliferative is a combination of membrane splitting and proliferation simultaneously. Membrane splitting causes proteinuria, which is often nephrotic range, and inflammation proliferation causes rupture of the capillary, which is nephritic syndrome. Right? So it's combination of nephrotic and nephritic. The second, and immune complex mediated MPGN can be because of infection. Like any infection can cause immune complex mediated MPGN. Could be part of the autoimmune diseases. If you remember SLE, so stage 3 and stage 4 SLE nephritis were actually membranoproliferative GN. Okay, and similarly, it can also be a part of the cancer such as myeloma and other malignancies. The second type of the membranoproliferative GN is C3 nephropathy, complement protein 3 mediated nephropathy. Now, normally this complement protein 3 is part of the alternate complement pathway. Remember, there are two pathways, classical pathway and alternate pathway. Classical pathway involve 1, 2, and 4, whereas, and then this 4 activate the complement 3. Whereas, so 1, 2, 4, and 3. This is the sequence 1, complement 1 activates complement 2, which activate complement 3, complement 4, and then complement 4 activate complement 3. Alternate pathway bypass the first three steps, C1, C2, and C4, they are bypassed. It directly starts from the C3. So C3 is a major player or the initial player or the opening batsman of alternate complement pathway. So anything which can activate the alternate complement pathway can activate the C3 nephropathy as well. Okay, and the purpose of alternate complement pathway is that it is readily available for the infections and for any infection in the body. Okay, classical complement pathway actually needs the formation of the immune complexes. Immune complex is a combination of antigen and antibody. So that means by the time unless there are antibodies, you cannot activate the classical complement system. So antibody formation will take 7 to 10 days because the immune system needs to be activated, which will start making antibodies. So whenever there's an infection, classical complement pathway takes 7 to 10 days to become active because that needs the presence of antigen and antibody both in the form of immune complexes to activate the classical pathway. Whereas alternate pathway is readily available, is immediately available, it's not as strong, but it's readily available. It doesn't need the presence of antibodies. So that's why the alternate pathway is the main pathway which starts working immediately once the infection starts. So any infection can trigger the alternate pathway very easily. Okay, and alternate pathway doesn't need the presence of antibody. It can just be activated by the antigen. To give you an example, gram-negative bacteria has a lipopolysaccharide, and that lipopolysaccharide can activate alternate complement pathway. Any antigen, any infection can activate the alternate complement pathway. And C3 is a main player or the opening batsman of alternate complement pathway. So that's why C3 nephropathy is often triggered by the infections. Remember when we talked about the post-infectious glomerulonephritis, I said there are 5 main types of the glomerulonephritis which can be activated by the infection. And one of those was post-infectious. Second was C3 nephropathy. So C3 being a part of alternate pathway is activated by the infections. So C3 nephropathy, very common trigger is any underlying infection, and it can be confused with IgA nephropathy. because C3 is also preformed in the blood and Ig is also preformed in the body. So both doesn't take longer time to become active. And both of these, they involve the alternate, they work through the alternate complement system. Now, because C3 nephropathy, C3 protein is part of normal complement system in every human body, but it doesn't cause C3 nephropathy in everyone. So there is some predisposing factors for patients who get C3 nephropathy. Now remember, C3 is a part of complement, which is alternate pathway, and alternate pathway, as I said, is ready to fight, ready to become active. So to keep it under regulation, there are regulatory proteins in the complement system, like protein H, protein B. There are different complement regulators. If any of those regulators is genetically deficient or defective or absent, then there's a there's a lack of this regulation of the complement system, and the C3 becomes hyperactive, and that can lead to C3 nephropathy. Secondly, this C3 is broken down by the C3 convertase. That is an enzyme called as C3 convertase. Some people have a genetic abnormality of this enzyme, C3 convertase, and that causes C3 deposition, C3 accumulation in the blood, and C3 deposition in the glomerulus. In certain conditions, such as in autoimmune diseases or in cancers, lymphocytic malignancy, they can produce antibodies against this C3 convertase. The enzyme which breaks C3 or which activates the C3, which converts C3 convertase, if there are antibodies against this C3 convertase, that antibody is named as C3 nephritic factor. You might have heard about the C3 nephritic factor. So C3 nephritic factor is basically an antibody against C3 convertase, and it leads to accumulation of C3 in the blood, and then C3 get deposited in the kidney. Okay, so infections can trigger C3, or genetic predisposition is required for the infection to trigger this C3. Okay, so C3 nephropathy is usually seen in patients who have deficient complement regulators such as protein H, protein B. Also in patients who have C3 convertase deficiency, genetic one, or in patients who have a C3 nephritic factor, which is basically antibody against the enzyme which act on the C3, okay, C3 convertase enzyme. These patients, when they get infection, the C3 level goes up in the blood, and this C3 start depositing in the kidney. Now, in the kidney, the C3 has two options, two patterns. One of the pattern is it gets deposited within the basal membrane, and the whole of the glomerular basal membrane is studded with the C3. Okay, so that is called as a dense deposit disease. So one of the type of C3 nephropathy is a dense deposition disease, which means the C3 is deposited within the basal membrane, and the whole of the basal membrane is fully loaded with the C3. Okay, there's no space left. In that case, there's no splitting of the basal membrane, but it's a subtype of the membranoproliferative, and it's called a C3 nephritic syndrome. The second pattern is C3 gets deposited in subendothelial location and in the mesangium and activates the inflammatory system. Remember, in this case, this is only the C3. It's not the immune complex deposition. It's just a C3 deposition in the glomerulus, in the subendothelial location, or in the mesangium, or both, without any immune complex. But because C3 is a major player or opening batsman of alternate complement system, it can activate the inflammatory system and causes inflammation there. And it will cause membranoproliferative GN. So just to summarize, membranoproliferative GN has two main types: immune complex mediated. Immune complex mediated mean there will be antigen antibody deposition in the glomerulus, in the subendothelial and mesangial location, along with the classical pathway of the complement system with C3 and C4, and the serum level of the C3, C4 will be low. The second is C3 nephropathy, which is usually has a genetic predisposition or C3 nephritic factor. Okay, if it happens in the adult age group, it's most likely because of the inhibitors or antibodies against the C3 nephritic factor, which are produced due to any autoimmune disease or because of the lymphocytic malignancy, such as myeloma or lymphoma. Okay, and C3 nephropathy has two main patterns. One is dense deposit disease, with this less inflammation but more deposition within the basal membrane. And second is mesangium and subendothelial deposition of the C3, causing inflammation and proliferation. Okay, these are the main types of membranoproliferative. And as we discussed before, because it involves the membrane plus it causes inflammatory proliferation. So there's a nephritic pattern as well as there's a nephrotic pattern, both together. Okay, and this is one of the worst form of the of inflammatory glomerulonephritis one can imagine, and it can be triggered by infection, autoimmune diseases, or malignancies. Okay, now how do we diagnose it? Basically, like any proliferative glomerulonephritis, renal biopsy is needed, and biopsy will show the deposition of, depending upon if it's immune complex mediated MPGN, so it will show deposition of antigen and antibodies and classical complement pathway C3 and C4. If it's a C3 nephropathy, it will show the deposition of C3 either in the basal membrane, which is dense deposit disease, or in the mesangium and subendothelial with inflammation. Okay. The treatment of the membranoproliferative, because it usually is quite severe one, it needs immunosuppressive therapy. Okay. Depending upon the severity, the suppression can be methylprednisolone and cyclophosphamide, or it can be methylprednisolone and rituximab, depending upon the severity. If it's less severe, oral steroid along with mycophenolate can also be tried. Okay. In cases where there's a C3 nephropathy, because C3 is a part of the complement system, in those cases, complement inhibitors such as eculizumab also has a role in addition to the immunosuppressive therapy. So C3 nephropathy causing MPGN can be treated is the option is includes eculizumab, which is complement inhibitor, in addition to the immunosuppressive therapy. Okay, so that is about the membranoproliferative GN. Now the second one, we will talk about cryoglobulinemic glomerulonephritis, cryoglobulinemia and GN. Remember, the word cryo means cold. The globulins are antibodies which become active at a cold temperature. They are called as cryoglobulins. Okay. Now, these cryoglobulins, they become active when the body temperature is cold. This phenomena of cold-induced activation of globulins is okay in the skin because skin becomes cold. But this cold-induced activation of the cryoglobulins doesn't explain the renal involvement in the cryoglobulinemia because there's no cold temperature in the renal system or in the internal organs. So involvement of the internal organ is not temperature induced. Involvement of the skin in cryoglobulinemia is temperature induced. Cold temperature activates the cryoglobulins in the skin and can involve the skin capillaries and small circulation of the capillary of the skin and can cause skin vasculitis or Raynaud's phenomena or petechiae and purpura in the skin. But involvement of the glomerular system in the by the cryoglobulinemia is not merely because of the cold temperature. So that means the cryoglobulins can involve the glomerulus by immune complexes. So these cryoglobulins, they cause glomerulonephritis by making immune complexes. It's not just merely deposition of cryoglobulins within the glomerulus due to cold temperature. No, that doesn't explain the kidney involvement. That explains the skin involvement, but not the kidney involvement. So deposition of the cryoglobulins in the kidney is through the immune complexes. The basic Cryoglobulinemic glomerulonephritis is immune complex mediated glomerulonephritis. This was the point which I took so long to emphasize, that renal involvement is not because of the temperature. Renal involvement is because of the immune complex formation. Okay, right? When the patient has high cryoglobulins in the blood, almost one third to one half of these patients who have high cryoglobulins in the blood in a significant quantity, almost half of them, they have one third to half of them can have the renal involvement. And in the kidney, the most common site of involvement is glomerulus, okay, through the immune complex deposition, not through the temperature. I'm repeating this again because it's important concept. Okay, if you look at the cryoglobulins, there are three types of the cryoglobulins. There is type 1, type 2, and type 3. Type 1 is monoclonal. Monoclonal means a single type of antibodies, okay? Single type of globulins, okay? And monoclonal is almost always due to an underlying lymphocytic malignancies. Whenever you hear the word monoclonal cryoglobulins, that means you're talking about the cancer, okay? Right? So monoclonal cryoglobulinemia is because of the lymphocytic malignancies, because lymphocytes are the one which produce antibodies, which produce globulins. Okay. So lymphocytic malignancies such as lymphoma, Hodgkin lymphoma and non-Hodgkin lymphoma, lymphocytic malignancies such as multiple myeloma, lymphocytic malignancies such as chronic lymphocytic leukemia, okay, and other variants such as MGUS and those things, they can cause monoclonal cryoglobulinemia. Type 2 and type 3, they are type 2 is oligoclonal and type 3 is polyclonal. Okay. Oligoclonal means that more than one antibodies are produced, more than one type of antibodies is produced. Usually is a polyclonal IgG and monoclonal IgM in oligoclonal. Okay. Whereas type 3 is polyclonal, means polyclonal IgG and polyclonal IgM. Okay. So type 1 is monoclonal IgM or monoclonal IgG. If there's a or, either there's a IgM or there is IgG, and that too of one single type, that is monoclonal IgM or monoclonal IgG. This is type 1. Polyclonal IgG and monoclonal IgM is type 2. And type 3 is polyclonal IgG and polyclonal IgM. Even if you don't remember these things, it's not important. The most important concept is, if it's purely monoclonal, you are dealing with cancer. If it's not purely monoclonal, this is infection or autoimmune. Okay, so monoclonal cryoglobulins are cancer, lymphocytic malignancies, whereas if it's not monoclonal, either it's oligoclonal or polyclonal, this is not cancer, this is infection or autoimmune. So important is monoclonal is cancer. If it's not monoclonal, it's not cancer. If it's not cancer, it can be infection or it can be autoimmune. Okay. Out of these three, the renal involvement is more common with type 2, oligoclonal type of cryoglobulins. They have they explain 70 to 80% cases of cryoglobulin induced glomerulonephritis. Okay. Whereas polyclonal is the second most common, 10 to 20% cases of cryoglobulin induced glomerulonephritis, they are because of the polyclonal or type 3 cryoglobulins. Monoclonal antibodies involving the glomerulonephritis is rare. It's less than 5% cases are because of the monoclonal. Okay, so more common is oligoclonal. Now, what they do? These cryoglobulins, they make immune complexes, and they make immune complex with the antigen which has triggered their production, and then these immune complexes they deposit in the subendothelial location and in the mesangial location, in the mesangium and subendothelial. Remember, post-infectious was subepithelial deposition. Okay, whereas cryoglobulin is subendothelium and mesangial deposition. Because they're subendothelial, so they're close to the blood. When they're close to the blood, they're more immunogenic, so they cause severe inflammation. They can trigger more stronger inflammation However, because they're closer to the blood, they're relatively easier to clear. Okay. Now, this is the one important concern. Because they work through the immune complexes, so that means they will activate, they will use the classical complement system as well. So cryoglobulinemia involving the glomerulonephritis, causing glomerulonephritis, uses the complement system, and that means serum complement level will be low in, because it's immune complex mediated disease. And when there's a deposition in the subendothelium and in the mesenterium, so that will cause inflammation and proliferation of the mesenterium and capillary endothelium, with all the consequences which a proliferative glomerulonephritis can cause, such as hematuria uh, and renal failure. So this is one aspect of the cryoglobulinemic glomerulonephritis: immune complex deposition, which are made up of cryoglobulins and antigens. And this immune complex activate the classical complement system, C3, C4. The serum level of C3, C4 that drops during the active inflammation. And this immune complex deposition with complement activation brings the inflammation in the glomerulus and causes inflammation and damage, leading to nephritic pattern or nephritic syndrome. The second important pattern of the cryoglobulin involving the glomerulus, which is not seen in any other proliferative GN, is a protein plug formation in the glomerular capillaries. Now, this is important to understand because this will help to differentiate cryoglobulinemic glomerulonephritis from other types of glomerulonephritis. One, when we will do the immunofluorescence, we'll find there a cryoglobulin deposition within the glomerulus and subendothelium and mesangial location. Okay, and using the complement deposition and inflammation. Second, this immune complex deposition plus complement deposition is common for many other proliferatives, such as lupus can cause this. Post-infectious was the similar one, although that was subepithelial. And cryoglobulinemia is also immune complexes plus classical complement system involvement and inflammation of the mesangium and the capillary endothelium. So this pattern is quite common with many other proliferative glomerulonephritis. So that will not help us to differentiate. Yes, immunofluorescence, when it will demonstrate the presence of cryoglobulins in the kidney, in the glomerulus, that will help to differentiate. Okay. The second important point, which is not present in any other proliferative glomerulonephritis, is presence of the protein plugs in the capillary lumen. Okay. Now this has a different implication. Number one, this proteinaceous plugs, they are not present in any other proliferative GN except in cryoglobulin. So that it helps to differentiate cryoglobulin from other types of proliferative GN. However, because there are protein plugs in the capillaries within the glomerulus, now, and which include the capillary lumen, so it can be confused with any other disease which block the lumen of the capillaries, such as diseases which make platelet plugs within the glomerulus capillaries, such as TTP and HUS, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. They both make platelet plugs within the glomerular capillaries. Okay, there is a plug that will block the capillary. Consequences will be same: kidney ischemia, renal failure, okay, and glomerular damage. Right. So either that plug can be made up of platelets, that can be made up of red blood cells, that can be made up of proteins. If it is made up of proteins, this is cryoglobulinemia. If that plug is made up of platelets, that is a TTP or HUS. If that plug is made up of clotting factor and platelet, this is DIC. And if that plug is made up of red blood cell, this is microangiopathic hemolytic anemia. So there are four types of the plugs which block the glomerular capillaries. One, plug made up of platelets, which is TTP, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. They both have a platelet plugs blocking the glomerular capillaries. Second is clotting factor and platelets, both, which is DAC and antiphospholipid syndrome. Okay, they make clotting factor plugs within the glomerular capillaries. Third, plugs of the red blood cells, which is microangiopathic hemolytic anemias, right? And fourth is plugs of the cryoglobulins, which happen in cryoglobulinemia. Whenever there is plug formation within the glomerular capillary, the consequences are the same: acute renal failure and glomerular ischemia. Okay, so because cryoglobulinemia can cause plug formation within the glomerular capillaries, so it can be confused with any other microvascular disease such as TTP, such as hemolytic uremic syndrome, such as antiphospholipid syndrome, such as DAC, and such as microangiopathic hemolytic anemias. Remember, all the other types of the plugs, which are made up of platelets or red blood cells or clotting factor, they are not immune complex mediated. They don't have immune complex deposition in the glomerulus. They don't activate the complement system. Okay, so there's lack of immune complex deposition, there's lack of cryoglobulin deposition, and there's lack of complement deposition within the glomerulus. And the serum complement level is also often normal in these cases, other than cryoglobulin. Cryoglobulinemia causes immune complex deposition along with the protein plugs in the capillaries. So they're not only plugs, there is also immune complex deposition, and there's also complement activation, and there's inflammation in the mesenterium and capillary and endothelium in addition to the plugs. Whereas TTP, hemolytic uremic syndrome, DAC, antiphospholipid syndrome, and microangiopathic anemia, they make plugs, they block the glomerular capillaries, but they don't have immune complex deposition, they don't have complement activation or complement deposition, and they don't have mesangial and endothelial proliferation. So I hope that clears. But presence of the proteinaceous plugs in the capillaries is a very important diagnostic clue for the cryoglobulinic GN. Okay, this is important because sometimes patient just has a renal involvement of the due to the cryoglobulin. They don't have a high level of cryoglobulins in the blood. Okay, and they don't have any other systemic manifestation, extra renal manifestation of cryoglobulinemia. So in those cases, it becomes difficult. In such cases which don't have the elevated cryoglobulins in the blood, and they don't have any extra renal manifestation of cryoglobulinemia, in those cases, the diagnosis is established by immunofluorescence showing deposition of the cryoglobulins in the mesenterium and endothelium, subendothelial location. And secondly, presence of the cryoglobulin proteinaceous plugs in the glomerular capillaries. Another important feature which help to differentiate this cryoglobulinemic vasculitis, cryoglobulinemic GN from the other proliferative GN is, for unknown reason, cryoglobulinemic deposition and inflammation, it usually spares the capillary endothelium. It's not endothelial involving proliferation. It mainly focuses on the mesenterium. It mainly causes mesangial proliferation. It rarely involves the endothelium or the Bowman's epithelium cells. So endothelial proliferation is rare, and crescent formation is also rare in cryoglobulinic GN. Okay, so these two findings, they also help to differentiate cryoglobulinemia from other type of the GN. Okay, all right. Now, when the cryoglobulinemia is suspected, what sort of workup is important? The important thing which I would like to highlight is detection of the cryoglobulins in the blood. Okay, remember, the most common fault where we miss cryoglobulins in the blood is a sampling error. Okay, cryoglobulin sample should be taken fresh sample, and then it should be kept at a temperature around 4 degrees. Okay, because the sample should be transported to the lab immediately, and the lab should be given a note that we are suspecting cryoglobulinemia, so that they can do the needful. Okay, what they do with the sample is there are two steps. One is the measurement of cryocrate. Okay, basically, when the sample is frozen at 4 degrees, the cryoglobulins will become active and they will settle down, and that the sediment actually measure the is called as cryocrit, cryocrit, that actually measure the quantity of the cryoglobulins in the blood. And then those cryoglobulins which settle down, they are separated by electrophoresis. Okay, so first step is measurement of cryocrit. Second step is electrophoresis. Electrophoresis will separate the different types of the cryoglobulins based on their size and the charge. Okay, and that will help us differentiate: is it monoclonal? If all the cryoglobulins they accumulated one single point on the electrophoretogram, this is monoclonal. And if there are multiple spikes or more than one spike, this is either oligoclonal or polyclonal. Okay. So cryocrit measurement and then electrophoresis, these are the two steps which are done on the sample, and the sampling technique is very important. It should be fresh sample, which should be transported immediately to the lab under a strict temperature regulation, and the lab should be informed. Now, as I said, the monoclonal cryoglobulins are cancer, they are malignancy. Okay. Oligoclonal and polyclonal are mostly infection or autoimmune. Okay. So if you have diagnosed the patient with a cryoglobulinemic glomerulonephritis, the treatment of the cryoglobulinemic glomerulonephritis depends upon two things. One, is there any infection or there's no infection? Is it infection induced or is non-infectious? Infectious cryoglobulinemia versus non-infectious cryoglobulinemia, number one. Number two, what's the severity of the disease? The severity of the disease is based on few factors. One is if the internal organs are involved. For example, patient has a glomerulonephritis, or patient has a pulmonary hemorrhage, or patient has a CNS vasculitis. Okay, so the involvement of the internal organs with the cryoglobulin means it's a severe cryoglobulinemia. Okay. Secondly, in the skin, if there is skin ulcers or skin necrosis, okay, this is a severe cryoglobulinemia, even if just skin is involved. Okay, lack of ulcers and lack of necrosis in the skin is mild to moderate cryoglobulinemia, anemic cutaneous vasculitis. Okay, and third is the severity of the systemic inflammation. So, how do we treat it? If the patient has infection and the cryoglobulinemia is mild to moderate, mean there's no internal organ involvement, there's no kidney involvement, there's no brain involvement, there's no lung involvement, and the skin involvement is also not having ulcers or gangrene or necrosis. Okay, so it's mild to moderate, which means no internal organ involvement, and plus even the skin involvement doesn't have any ulcers or any gangrene or any necrosis. So mild to moderate cryoglobulinemia due to infection, the treatment is treat the infection. Usually the treatment of infection is enough to treat a mild to moderate infection-induced cryoglobulinemia. Okay. If the infection-induced cryoglobulinemia is severe or is involving the internal organs or is causing ulcers and gangrenes of the skin, okay, then it needs infection treatment to be started immediately, plus introduction of the steroids or the immunosuppressants. Okay, because if we just use immunosuppressant, it, number one, it will not cure the underlying trigger. Second, it can worsen the infection. So we have to treat the infections before or simultaneously along with the immunosuppressant. And the introduction of the immunosuppressant depends upon the factor that if there's internal organ involvement, or if there's any internal organ involvement, or if the skin involvement is severe. Right? And if it's a non-infectious cryoglobulinemia and it's mild to moderate, then that can be managed only with the steroids. Okay. But if it's a severe skin involvement causing ulcers and gangrene, or there's internal organ involvement, or there's a severe systemic inflammatory findings, then the patient will need a stronger immunosuppression such as methylprednisolone and cyclophosphamide or methylprednisolone and rituximab. Okay. In this case, rituximab is preferred over cyclophosphamide because rituximab is B cell depleting antibody, is a CD20 antibody, and it will reduce the production of cryoglobulin from the lymphocytes. So rituximab is superior over cyclophosphamide in cases of cryoglobulinemic vasculitis or cryoglobulinemic glomerulonephritis. There is a role of plasma exchange if the cryoglobulin concentration is too high, number one, or if there's a hyperviscosity syndrome because of plasma exchange, because of cryoglobulinemia, or if there's a pulmonary hemorrhage. So severe cryoglobulinemic vasculitis, which is not responding to methylprednisolone and rituximab, or methylprednisolone and cyclophosphamide, that needs addition of plasma exchange. That will filter all the cryoglobulins and that will give a quick response. Similarly, if the patient has a severe pulmonary hemorrhage, that will also need a plasma exchange because plasma exchange acts quickly. Similarly, if there's a hyperviscosity syndrome, which is quite common in, especially in type 1 cryoglobulinemia, right? So hyperviscosity is also treated by plasma exchange. Okay, hyperviscosity actually happens because of too much proteins in the blood. Okay, blood becomes very thick and sluggish to flow. That's called as a hyperviscosity syndrome. It can happen because of many cells in the blood, or it can also happen because of many proteins in the blood. And cryoglobulinemia is especially one type of one cause of hyperviscosity syndrome as well. Remember, because type 1 is monoclonal cancer-induced cryoglobulinemia, so that produces a lot of quantitatively, they're huge in quantity. Plus, most of these cancers, they produce IgM. Remember, the IgM is a pentamer, is a combination of 5 antibodies molecules. So one IgM molecule is quite huge in size. Okay, it's the biggest antibody. So production of IgM and in patient with the cancer, usually the most common cause of cryoglobulinemia induced hyperviscosity. So hyperviscosity is more common in monoclonal, whereas GN is more common in polyclonal and oligoclonal and polyclonal. Okay, so that is about the cryoglobulinemic GN. I'll stop here.